It really has been a privilege to set up a vestibular diagnostic lab here at Swedish. They were very kind and got us all the state-of-the-art new equipment that's out there, and I'd like to tell you how it's working and some of the things that we found particularly useful that you might easily be able to bring into your own practice. So first of all, why do we do vestibular testing? It's not on every dizzy patient, and it certainly doesn't eliminate the need to take a careful history. So it's when you're not sure after you've taken your history what's going on that you might need some additional information. In the office, you might be able to check for benign positional vertigo yourself with or without Fresnel lenses. Meniere's is probably a diagnosis based on the clinical history, the hearing loss, and we don't need to do vestibular testing. It actually complicates that diagnosis. But sometimes you really do need more information. Is this a vestibular problem at all? This dizziness the patient's complaining. Could it be migraine? For those kinds of more complex questions, full vestibular evaluation usually comes in handy. But again, it doesn't replace your clinical context, your office exam, and careful thinking about whether you really need to do this or not. The other time when you really might want to get vestibular testing is if you're thinking of ablating an ear, a neuroma, a severe intractable Meniere's. It really helps to know what the function of the good side is. You know, back when I was young, we used gentamicin drops in kids' ears because we didn't have other safer alternatives. So there are a lot of adults walking around who don't realize they have a unilateral vestibular loss. If you happen across one of those in your practice, and now you have an acoustic in the good ear, it helps to know that before surgery because it helps you to plan your rehab. Patient can meet with rehab specialists, plan their treatment, understand what's going to be involved in recovery a lot more specifically, instead of waiting till they're post-op in bed trying to recover from a craniotomy and now, oh, they need a whole course of vestibular treatment. What is that? Who does it? How do they get there? It's easier to set that up pre-surgery instead of post-surgery. So the testing will help you plan, is this patient who really might need the surgery? Is this an only balanced ear? What does that mean and what do I have to be prepared for? Okay. So what vestibular testing can do for us, and by the way, I'm an otolaryngologist, so I've got a real orientation toward how is this practically useful for a surgical practice to localize a lesion. I'm going at it from the direction of having been trained in, I don't do it anymore, but trained in surgery. So I want to give you very useful, practical, succinct information. What's the deal here with this patient? So where is the lesion? This is a question I think vestibular testing can help to answer. Is it peripheral? Might it be central? Which ear, etc. And also, the other really helpful thing that testing does is to assess compensation. So let's say your patient had vestibular neuritis, or they lost their hearing, labyrinthitis. It's 6 months later, and they're still coming in complaining, I'm really dizzy. So the story was pretty classic in the beginning, acute onset, days in bed, world spinning, but they're still not better. Well, why aren't they better? And you've got a number of options there. Was this the only ear and the neuritis knocked it out? Did it kick in their migraine and now they're got a central overlay? What's going on and why aren't they better? Maybe they've tried a little local physical therapy, they're not better. What is very helpful about modern vestibular testing is it not only tells us which ear and how much, it can tell us how much the good side has been able to take over. So we can measure and quantify compensation. And this is fascinating, so I wanted to take a few slides to talk about compensation, and we'll get to it as I go along. We can't measure disability, and I don't do disability evaluations. That's right off the front. They call the office. I'm telling them I don't do disability evaluations. Testing doesn't assess disability. Disability is complicated. It's social. It's how much support you have at home, at work. Do you have to drive? What's your transportation? All kinds of stuff. And I leave that to people who have spent their careers figuring out how to assess disability. That's not the role of vestibular testing. Again, it doesn't replace your careful history and physical. It doesn't determine a course of treatment. It will describe where the patient's at right now and maybe give very helpful information to our rehab specialists, but it doesn't determine treatment needed. And maybe we can assess some of the vertical semicircular canals with head thrust testing, but in general, all of our classic calorics and chair just assess the horizontal semicircular canals, so they're somewhat limited. So our first question when we see a vestibular test result is there a caloric asymmetry? Calorics is a terrible test. It depends on the water being the right temperature, the ear canals being fairly straight, the technician kind of shooting from the same angle to each ear, which can vary, and it's very affected by the patient level of cooperation. Patients have to be alert but calm during a caloric. If they're too sleepy, you can put ice water in their ear and you will not get nystagmus. It's a certain brain wave that you need to get nystagmus. If they're too nervous, you're not going to get nystagmus. That's why they do that thing where, name things that are green, girls' names. They're trying to get the patient into this groove of alert wakefulness, concentration, not too sleepy, not too jittery, because it affects the waveform of the nystagmus. So think of all these factors: wax, anatomy, technical issues, technician issues, and lastly, the level of the brain function issues. And calorics is an extremely variable, terrible test. You can repeat it on the same person day after day and get different results. And that's the way calorics are. But it's the only test we have that compares left to right and gives you an individual reading on each ear canal. So it has a role, but a very limited role. Don't over-depend on your calorics. Okay, so the thing I depend on the most, and I probably couldn't function without, is a rotary chair. And it looks like this. The new rotary chairs are goggles in an open surround. There's no more telephone booth that we have to put patients in, because the signal to noise ratio from the goggles is good enough that with a wide screen and a dim room, we can do all the testing we need in an open rotary chair. So now it's just a chair. In fact, if you didn't want to computerize your analysis, you could take the goggles and put a patient in this chair and move them and see what their VOR is doing. And occasionally, if my big chair goes down, the computer fritzes out, I might do that, because you can get that information from the new goggles. They're good enough that they're going to be seeing VOR, and you can look and compare how is the rotation to the right and the left. It tells us how the vestibular system is working. The lateral canals, both canals, are participating. So let's say you went to the drilling lab and you learned how to do a nerve section, and you went back home and you did a nerve section on a patient with intractable Meniere's. They would have spontaneous nystagmus immediately after because of the difference in the function of the two ears. After about 3 days, spontaneous nystagmus starts to decrease. If we waited about a month and they're an average patient and they're moving their head, and we put them in a rotary chair, their results are normal. Because the good ear has been able to take over and stabilize vision during head rotation. Basically, what is vestibular ocular reflex? It's looking at a target, an object of regard, and being able to stabilize it while your head moves. In the acute period, postoperatively, they're not going to be able to do that. But after moving their head around for a month or so, most people, the good ear takes over, and we see a normal chair. So it's pretty good. There's been several papers published on parameters after vestibular nerve section and how the vestibular ocular system can run just with a good ear. But then this raises the question, how about those people who say, oh, I'm still dizzy? That's where the chair comes in handy, because sometimes they don't compensate. Maybe they're taking too many Valium, maybe they're not moving their head, maybe they've got bad migraines, maybe they got a neck problem. For some reason, maybe they're not compensated, and the chair will tell us, because they won't have the same gain going toward the operated ear as the unoperated ear. And we can say, oh, you're not compensated for your vestibular loss. And then that helps to guide the therapy. So we can also assess maybe both ears are out. For some reason, maybe this is a patient who didn't have function on one side, you operated on the other, and we drop function in both sides. So if you move your head really fast like that, you're getting about 3 hertz of speed, angular acceleration. If you do calorics, I'm sorry, there's a typo, it's 0.002 hertz. Very slow. Caloric's warm and cool, the endolymph slowly moves, very slowly, versus about as fast as you can go moving your head is 3 hertz. So this is your frequency range that you can test vestibular-ocular reflex. Typically, in our day-to-day function, we're kind of going like this. And the rotary chair is perfect for testing these frequencies, 0.01, 0.02, 0.04. The frequency is the inverse of the cycle. So let's say a 0.5 is 1/2. And so the cycle is 2 seconds. So 1, 2, 1, 2. This is the frequency the chair can test at its highest speed. And then the slower ones are here. So this has a lot to do with what our day-to-day head movement is like, and the chair is very good at assessing those frequencies. Head thrust testing, the new thing with the really tight goggles that have to like glue on because you can't let them move, and you have to be careful not to touch them when you head thrust, is a little more technically difficult to do, but it's testing up around 3 hertz, very high frequency in order to get the results you need. And it's also not giving us a lot of information easily about compensation. So even though we have head thrust testing now, I have to say I'm still a big fan of rotary chair testing when you're concerned about measuring compensation. And here's an example. I don't know if I have a laser. Don't think I have a laser. Let me point. So here's all the frequencies we test, 0.01 to 0.5. So this person has pretty good gain. You want it to be up in the white. But look, their clockwise rotation to the right is reduced. It says clockwise rotation weaker compared to that to their left. So this might be a patient with an acute right unilateral weakness, or someone who has a chronic right weakness who isn't sufficiently compensated. Then we have to tie in the clinical history, but the rotary chair can tell us this, and no other part of the test easily can tell us the degree of compensation. Rotary chair is also helpful if things look bilateral on caloric, but you're not sure. You know, again, calorics are not the most sensitive test. They're not very reliable. So if there's a question of bilateral loss, I like to do the chair in order to verify it. It's also pretty easy to do with kids, with people who aren't going to really put up with the caloric, because you're sitting in a chair and it's kind of like playing a video game. People really think it's fun. You know, you can make your targets little smiley faces. You can do all kinds of cool stuff that make the chair really appealing to kids. Or little kids can sit on a parent's lap and look at the light and move. So we can test a range of ages and cooperation levels in the chair that you just couldn't easily do calorics on that population. So a lot of cochlear implant kids, the question is, do they have vestibular function? And that's real easy to do if you just plop them in a chair and rotate them around a little bit. So following an acute unilateral vestibular loss, remember your one nucleus, vestibular nucleus, is firing, the other is decreased. The brain sees that difference, it thinks you're turning, and it sends your eyes to catch up you, so you get spontaneous nystagmus away from the weak side. You also generally dampen the whole vestibular system. The brain is trying to make you stop spinning, so it sometimes dampens everything in the acute period, and you'll also see some decreased gain in the good side. Usually after a good vestibular neuritis whomp, the nerve does not recover. It's been injured, and it's not a nerve that takes kindly to this. And so spontaneous recovery of the nerve typically does not happen. It's, again, we're depending on the good ear being able to take over running the show to modulate up and down to let the brain know, are we moving or not? So that process begins first with our head still. Spontaneous nystagmus stops, about 3 days. And then it's very variable, the time course of when people compensate for dynamic movement. How does the brain figure out how to do that? It runs some off the good ear. It can also use different sensory modalities, particularly the neck. Cervico-ocular reflex can replace about 80% of vestibular stabilization, and we can even test it. Think about it. Keep the head still and move the trunk, and you're getting cervico-ocular. You're getting the input from the neck without moving the head. So there's ways that we can assess cervico-ocular function. The brain looks for all kinds of different stuff. How can it use anticipatory saccades? You're going to turn that way, look that way first. People can get all these different tricks, visual tricks, neck system, proprioception, ramping up the good ear to compensate. But it's different for different people. People weight different sensory modalities differently. So figuring out what's your patient using to compensate and why isn't it working is really quite interesting. And the Rotary chair can help with that. So dynamic compensation occurs more slowly. It's highly variable and it's multifactorial. It's not a simple just rev up the firing on the good nucleus. There was a very good study by Koizuka who said after nerve section, the VOR asymmetry was the most effective information we have in evaluating the time course of compensation. So it's very asymmetric immediately, and gradually over time, again, the good ear takes over and you get the symmetric rotary chair gain. So it's useful for this. Ian Kurthoys, who's done a lot of work with head thrust testing, actually thinks, and that's when you rapidly thrust, that's the 3 hertz stuff and even faster, thinks the neck is playing a role there, that the sternocleidomastoid proprioceptors might be somehow tying in, amplifying, and helping to do these little covert saccades to keep vision in place. So the brain is searching for what it can use to stabilize vision from lots of different sources. That head thrust testing is way too fast for the vestibular nuclei to do, so they think it might be coming from a different place. So there's static compensation, there's dynamic compensation, and our rotary chair helps with all that. The other thing is that the computerized systems don't analyze torsion unless you've spent $40,000 on a camera that can look at the retina. So I tell my technicians, the little jumps on the recording thing are not going to be accurate. If you take a round ball and rotate it, the computer can't see that. It's looking for XY axis changes, and it's not going to see the round ball rotating. So you actually have to look at the screen, look at the eyes, and see if there's torsion. So that's important when you have your vestibular lab and you're working with technicians to really emphasize to them not to just look at the computer, but to look at the patient's eyes, because they're much better at torsion than any current reasonably priced computer system. I talked about head thrust. Here's how to do it. Without special equipment, you ask the patient to keep their eye on your nose. You move them this way. Usually it's better to thrust them toward the midline. Thrusting them toward the midline, they should be able to stay on your nose. If they go right by and have to jump back, that means it's weak on the side you thrusted to. So this is a good check, like you're in the hospital, patient got gentamicin, they're dizzy. Do they have a functioning vestibular system? Just bedside head thrust testing can be very helpful in seeing whether they can stay focused on your nose. No special equipment needed. But again, the new computerized systems will give you a little more information. I want to talk about VEMP real quick because I know I have to keep you guys on target. We have moved almost totally toward ocular VEMP. So why is that? I see a fair number of folks who come in who've been around, who don't have an explanation for their dizziness, and who have semicircular canal dehiscence. I think that's just because we opened a center. There's not a lot of people who have VEMPs around in the Pacific Northwest, and so these patients are coming in and we're getting a pretty high hit rate. So basically the otoconia on the utricle and saccule are sensitive to noise. It used to be particularly saccule, used to be a vestigial hearing system. So noise still triggers a response. And if you've got a dehiscence, it's almost like, the system doesn't have resistance. You just sort of, like a balloon, if it's really, or a ball, it's really full and tight, and you just poke it and you can't do much, But if it's got a hole on the other side, you poke it here and the other side goes vroom, like a half full balloon, soft, floppy. So an ear with a dehiscence has floppy fluid without a defined enclosure. So if you put noise into it, it's going to go vroom, hit into the utricle or the saccule, and you get a VEMP response. So sound stimulates it. The cervical VEMP you have to record from the neck, and you make the muscle tight, hard to do, and then you're looking for a decrease in its tension when you hear the sound. So the patient has to keep sustained neck turn. So people have tried all kinds of stuff, having the patient lay down, lift their neck up, hold it, keep holding it for like 15 minutes. Very hard for older patients. Plus you need a bed. Or then they tried, okay, let's turn your head and push this water bottle against the wall. Don't let it drop. Again, it's kind of hard to sustain your neck contraction that long. So there's a lot of noise that enters into your VEMP recording. Here is the montage we used in Cleveland, where we're recording from the SCM. Then we've got control electrodes here that we're comparing to. Whoops. And you get a VEMP tracing. You have to run thresholds. You start at 65, you go up and down. You see if there's abnormal thresholds. This whole thing takes 45 minutes to do a good job on. So there's a lot to it. I won't go over this. But here is ocular VEMP. You don't have to sustain neck contraction. All you have to do is look slightly up, maybe 20 degrees up. That's it. The electrodes are on the cheek, and they're recording from the inferior oblique muscles. It's a crossed response. You put noise in the left, the right eye jumps. Put noise in the right, the left eye jumps. If the jumps are too big, you're just running one train, it's suggestive of canal dehiscence. So all you have to do, you're not doing thresholds, you're not sustaining neck tension, you're just putting stickers on the cheeks and going click, click, click. Bingo. Takes 10 minutes. Patient's seated. Really fast and easy to do. So if you're just using VEMP to screen for canal dehiscence like I am, I would highly suggest the way to go. Now, and this is what your waveform looks like. And if it's really big like that, you've got a probable dehiscence. It's pretty clear cut when it's there. It just jumps right out at you. This is some interesting data. I'm sorry it's so small. Didn't realize it would come out small. But they're looking at the sensitivity and specificity of the cervical VEMP versus the ocular VEMP. Small numbers of patients, this is new. It's a new technology. The data's just coming out. I wouldn't hang my hat on it forever. But this is coming out in 2013, and I thank Liz Elkins because she gave me this slide. We're ending up with the ocular VEMP of sensitivity and specificity in the high 90s, almost perfect, 94, 100. It's really hitting these canal dehiscences versus your cervical VEMPs, highly variable, sometimes down to 54, 55, 60%. Then they pop around, they do go higher. But overall, would you like a test to pick up potential canal dehiscence that misses a fair number or that's more specific and sensitive? So preliminary data look like OVEMP is going to be better suited to our needs for diagnosis. And again, it's early. There aren't that many centers right now doing OVEMP, much less comparing it to CVEMP. So I'm looking forward to seeing what data comes out. If you have a conductive hearing loss, you can do this with a head tap instead of a sound. And surprisingly, in profound hearing loss, you still get a VEMP response. Doesn't seem to be related to cochlear hair cell function at all. So use vestibular testing prudently. Have in mind that new technologies are emerging that's making it faster, easier on patients, easier on you to get reliable information that you can use for clinical decision making. Thank you for your kind attention.